Anastasia Young. I'm a physical therapist, and I'm here today to talk a little bit about telehealth. Here we're going to do a mock e-visit. I'm here with Renuka, who is also a physical therapist and has close to 20 years of experience doing this on the road with athletes and other populations. And she can tell us a little bit more about herself if she'd like to. And I also have Anthony on the other side as our participant and our model.
Yeah, so I started doing e-health, what we used to call it back in the day, and it was a way to be able to provide some sort of input and feedback to someone who's having an injury and geographically you couldn't get to them. And my job as an international travel sports therapist allowed me to explore these different ways of conducting an e-health or a EPT, which is more trendy in today's world. And so what I would do is I would use Skype or I would use a FaceTime kind of an application rather than a sophisticated platform. And really, it's about staying true to what we do as a profession. As a physical therapist, we're movement specialists. And the ability to identify a flaw in movement and then to be able to make our best calculated guess as to how to help someone overcome that movement dysfunction, even though we are in separate geographical locations, is, I think, the essence of what we can do on TelePT.
Great. So what we're going to do today is we're going to have Anthony help us walk through a little bit of an assessment, and Renuka is going to be here to move that along as we go. So Anthony, can you tell me a little bit about what's been going on, how you've been feeling?
For me, I get a lot of lower back pain. Throughout the day, I get like a lot of pains, especially on my neck that goes into the top of my head, which creates like a tension headache. Also, I had a surgery on the side of the shoulder, so I sometimes get a lot of pain on this side where it feels like it's not completely attached, or I feel like I have a ball inside of there. So that's like another problem that I have, especially when I'm trying to rotate my arm.
Okay, so right off the bat, we're talking about someone who's been at their desk, facing a computer screen. So we already think about, just from those two little things Anthony told us, is, okay, we've got to fix something with his neck because positioning it would help with tension. Tension usually comes with some sort of shoulder or neck position. And the other thing is the history of a shoulder injury in the past. His arm position while he's at his desk or working is another indication of where I might want to give him some sort of guidance. But before we go, so at the front end, we already know what we're trying to target. And then, do you have any neck stiffness, or does the headache come on in the middle of your workday?
Sometimes, yeah, like especially when I'm sitting multiple hours, because I work on the computer most of the day. So especially when I'm moving towards like this, I'll get a pain on the bottom of my skull. So then that's I feel a little bit of pain over there that I'll start to move into the top of the head all the way down a little bit more.
And is it more like a throbbing pain, or is it more like a diffuse pain that kind of spreads down your middle back?
It's kind of like in the middle. It feels like someone has like the thumb and it's like sticking in there.
Perfect. So again, just the pain description is kind of leading us that maybe he's more upper cervical versus something where it's more lower back where he has to twitch about. So also he says that he looks at his computer screen. So this forward head down, staring at a screen is also an indicator of putting some stresses on those muscles in that upper cervical spine. And with the shoulder, does it feel like if you support it or if it's unsupported, does it matter?
It's where it doesn't really like matter. It feels like once again, like a thumb in there, like right in here, it feels like someone's pushing pressure in there, which causes a little bit more pain.
Yeah, again, this kind of pain here, thumb, is very localized, probably some sort of, just from a pointing perspective, could be some rotator cuff, which is having to hold that shoulder in its constant immobile position just by creating some tension. Okay, another quick assessment, now that we've kind of narrowed it down as to upper cervical, rotator cuff, more or load, gradual kind of thing, we can do a quick screen where we can just look at some range of motion. So can I have you just look up and down and side to side? And And what we're trying to do is, we're just trying to see, is he comfortable? We're looking more at his facial expression. Does he try to avoid a certain movement? And you can see, looking up and turning to his right side, he's a little more hesitant than he is when he's turning to his left. So again, we're thinking more unilateral, the side of the neck and the side of the shoulder is kind of bothering. And then if you want to do clearing tests like you would do in the clinic, you might just have someone just lift their hands up and down. And can you just go ahead and just raise your arms for me, come back down? And what we're trying to do is, can he do that with ease? Because right now, you also don't want to do multiple tests with someone where you cannot offer your service if you cause a flare up. So it's really about, what can I do? Where can I go? And what's the best information the patient can give me? So what I think, any pain, and then you want to do some sort of clearing questions, just to make sure that this is not an emergency. Given it's an upper cervical, where I think I'm leaning towards, you might want to ask if the pain is radiating down your arm. Is any pain radiating, or pins and needles in your fingers? Any signs of double vision or throwing up or things like that?
Double vision. No pain to my fingers, but definitely double vision.
And the double vision, does it come on with the onset of the headache?
Sometimes, yeah. Like if they get too much pressure in here, it comes in there. It gives me more of like a lightheadedness a little bit.
Yeah, and again, what this is showing, that it's really concentrated in that upper area. Now, double vision can go into a whole bunch of things, but this is obviously something he's experienced before. It's not his first time. So you might, as a disclaimer at the end of the session, ask them to keep an eye on it and then seek medical help. But for now, there's a whole bunch of self techniques you can now teach the patient. One really cool technique is just to relax the muscle. So you can always send them some stretches to do, but there's a technique which I like to use, which is more a Mulligan technique, and it's almost teaching the patient what to do. They also have videos online, so you can teach the patient online and then send them the video. So what I'm going to have you do, Anthony, I'm going to have you use your thumb or your index finger with kind of like a piggyback with your middle finger, and really just, on the side of your pain, and you really want to press really hard on that spot. So you want to kind of go back there and really press on it. And just try and keep your head straight so you're not turning away. And then while you're doing that, I want you to just try to do like a chin tuck so that you're pushing forward and back. And so you're it's like a counter pressure. And you're going to start to feel like a throbbing through that. And it might make your pain go up a bit. Is that starting to happen?
A little bit of pressure, yeah.
Yeah. Okay, so stay there. And if you can go maybe 10% deeper into that pushing sensation, stay there. And then you'll kind of feel like this is going to pulsate and kind of peak up a bit. And then it'll start to have a down curve.
Yeah, I feel a little less pressure now.
Yeah. And usually you want to hold this for like 45 seconds to 60 seconds. We're not anywhere near that yet, but you will kind of now start to feel something melting in your hand, like that pressure doesn't feel like a pressure anymore. There's the structures underneath, whether it's a ligament or muscle, whatever you're feeling, is going to start to feel a little warm and a little more soft and pliable. Okay, and then I'm going to just have you gradually gently come off that. And then I'm going to have you just look up and to the side and see if that's easier. And you'll already see you're going much more further back, right?
Yeah, a lot further back.
Yeah, a lot further back. And if you turn to your right, that's much more symmetrical. So what you might do at this point is, you might either cue the patient or tell the patient, every time you're starting to feel this, use this. And it could be their own self-management, their own self-pressure. This is something you would probably do in the clinic using joint mobilization and some traction, but you're not there across because of geography. So what you're trying to do is try to teach the patient self-management using these very same skills. And then, Anthony, what I'm going to have you also do is some chin tuck exercises. So when you are at your desk, when you say that you're going to stick your neck out, what you want to do is really think of pulling your neck tall and up. So you want to keep, yeah, but you don't want to hold your breath. And then what you want to do is you want to make sure that your elbows are kind of resting out. And so you're going to now start to feel an unweightedness in that shoulder.
Mhm.
And then what I'm going to have you do is imagine there's a screen in front of you. And if you have to go to look into that screen, think of hinging from your hip rather than sticking your chin out, and see if that kind of helps.
It's more like this.
Yeah. So what you're doing, yeah, but that's a lot of movement. So your screen's probably very far from you.
Mm.
So what you're trying to do is you're trying to just teach your body to lean in or sink into that chair rather than stick your chin out.
Mhm.
And trying to use what you have around you is a much better way to relax these muscles which are getting tense, because over time you're going to start to lift off your chair, and the whole idea is to sink into your chair. That's it.
Okay.
And you'll feel that relaxation and that tension.
Yeah.
Yeah. So Anastasia, what do you think of this assessment?
I think it's really good. I actually have a couple of questions for you, Renuka.
Mm-hmm.
So aside of those quick tests that you gave Anthony to kind of determine where we should go with our treatment, what other types of tests are really good in differentiating some of the patterns that we may see as therapists?
Right. So this was a very specific case, but I usually like to decide whether is the pain coming from a weight-bearing position or a non-weight-bearing position. And when it comes to this particular case, it's definitely the upper cervical spine is being weighed down by the skull. But in the case of his shoulder, it didn't really matter, and it didn't matter. It wasn't positional related. When it comes to the lower extremity, if you can decide whether it's a compressive or a non-compressive. So is my ankle hurting me at rest or when I'm moving it? So really about deciding whether tissues under compression are causing the pain or just tissues at rest. That helps you decide how much of the component is mechanical or how much of it is just inflammatory. So if someone says, I was out in the yard, I did X, Y, and Z, and now I feel like my whole body is hot, most likely you're thinking muscles are flared up, there was definitely a trigger and things like that. Or rather than someone saying, I'm constantly feeling stiff. When you can make that differentiation, the one who's feeling stiff, you can give them more movement-based exercises versus the one who's already irritated all these tissues. You might want to give them something to calm it down, like ice and maybe just simple isometrics to do. So that's really what I look at. The other thing I look at is it positional based? Being Maitland trained, it's always the painful sides on top. So if you're giving them resting positions, so say their back's hurting or their hips hurting, and you're giving them some sort of advice on how to sleep, it's just better to have that painful side not being compressed and getting irritated. So the other issue is if they have some sort of things where they can support those inflamed tissues. So sometimes a pillow propping up can be helpful. Just a scarf around the neck is really helpful if you're staring at a computer screen. And then when it comes to back support, it's really putting that support where it's easing the back pain rather than pushing on the back pain. So sometimes if you have lower back pain and you have a stiffer upper back, maybe supporting the upper back might just help decompress that lower back. And it might be coaching your patient online, just trying to find that sweet spot on the back of their chair.
Right. As far as low back pains, I know Anthony mentioned that he had some, and we can, use our test to differentiate this situation as well. Is this more of, is he stiff? Is he, more acutely inflamed, which I assume is probably more stiffness, considering we've been, right, Anthony, would you say that you've been having this pain for a while, or is it something that just happened today?
For a while now. It's like
Yeah,
it
and
helps like more when I'm walking for a longer period of time, and after a while, like it on my lower back, like all the way on the lower portion, feels like there's like a pain around the whole thing.
yeah,
Right?
and that makes perfect sense because you do have a sitting job. And when you're sitting for a while and then you want your spine, those segments to start supporting you when you're walking for a long time, those teeny inter spinal segments are getting fatigued, and then the big muscles take over. So it's really those anti-gravity muscles in your spine that don't really work a lot or have stopped working over a period of time, which kind of um, because you're not using it in that way. When you start to walk, it's like they fatigue so quickly that the big muscles take over,
Mhm.
and then it's that vicious cycle. So really training deep core muscles is a better long-term solution to chronic back pain than simple stretches and things like that. Because yes, it's good to stretch those big muscles because you don't want them to overpower and crush your spine. But in the long term, it's the stability of the inner muscles that is a better bang for your buck.
So I have a quick question. As a PT, we always are using different types of tests to kind of see what our interventions are doing for our patients. What types of functional testing would you use with Anthony's case, or what would what are the ones that you like going to, and why do you like going to those tests?
So walking is already something he said. So I would definitely look at how he was walking, just to check how much spinal rotation he has. I really like the extension test for the spine. The reason why I like it is because it gives me that idea of, can this spine actually move, and what's happening to those facet joints, what's happening to this. And it's this one simple way of knowing how much load that spine can take. So I really like that one. And if I'm really trying to differentiate between left and right, I might have someone just bend a little to the right or to the left. But an extension quadrant is a really quick screen, and it won't flare someone up if it's chronic back pain. It's the acute ones where you do not want to try to do too much, especially if you're at this big distance. The other one I like is just in standing, having them do a pelvic tilt. And just sometimes even to dissociate that pelvis in standing is so hard for so many people. It gives you an idea of what sort of motor patterning they're doing with, locked hamstrings or a stiff or a locked spine. And this inability to move that pelvis in itself is an indicator of what's happening. So those are the two, because I can actually observe it. I can actually see what's happening. So those are the two. And then sometimes I just get them to squat. It just allows everything to move together from the waist down. And it just sees how that curve's moving under load.
Cool.
And of course,
So
you'll ask screening questions of, pain going down the leg and, the same, just to differentiate between that radico versus just that low back lumbago kind of pain.
very good. So Anthony, would you mind getting up just so we can just look really quick? Let's see, can you show us how you're walking right now? Is that possible?
Sure.
So when someone's walking, you just really want to see them walking away from you. So, and all you're looking for is how are they stepping? Is there a lean to one side? And is there no lean? And you can see that the left to right, there's definitely an asymmetry. There is a bit of a tilt. So it could be that one side's weaker and one side's stiffer. And now in the clinic, you would have already palpated at this stage. So you would have some sort of idea. But Anthony, which side do you usually have back pain? Mostly on your right?
That's my right side.
Yeah, it does definitely look stiffer. And I'm going to have you walk back again so I can call it out for everyone who's watching. And you'll see that when Anthony walks to his right, he tends to lean a lot more to that right side. And the foot doesn't lift up as much as the left side lifts up. And that already is an indicator that this is a much more labored movement pattern rather than an eased movement pattern. So that's already telling you that's the side. Of course, you want to clarify with the patient, but I didn't want to overstep and guess it out on this. But does that make sense, Anthony? When you walk, it's much more effort to put weight into that right side, right there. Yep. And if I have you face away from this, yep, right there where that hip, you just put your hand, that's probably something that also gets tight.
Yes.
Yeah. Okay. While you're there, I'm going to have you face away from us. Yep. And I'm just going to have you lean back just a tad bit and come back up, and then just rotate a bit to your right and then to your left. While you're leaning back, sorry. And to the other side. And you'll see how much further he goes on that left side. And that's another thing, what I would call, like, it's called a grind test, but it's just an extension rotation. And you'll see that he's much more limited on that right side, which makes sense when he walks because the rotation to that side is also reduced. Does that feel different?
Yeah.
Yeah. Yeah, it does. That does definitely feel. Does that help, Anastasia, when you're trying to figure out which side do I want to treat?
Absolutely. You mentioned something about a squat as well. I know that could give us a lot of information in general. In Anthony's case, would you expect to see the same type of patterns as you do during your walk and your squat, or would you expect to find something different?
See him when he squats facing, when he's squatting, he might offload on that side. So when he's doing a squat, because he does not like to put weight into that side, so you might see a weight shift straight off the bat, even though he's going low. Or the other thing you will see is his trunk will start to bend at some point just to get deeper into the squat. So we can check that now.
So Anthony, can you give us a squat?
I can't see it.
Can you do it again? Yeah.
I have to see his screen.
Oh, could you talk for us?
Oh, sorry. Do you want to talk?
Yeah, it's just so like, yeah, can you turn around so we can do that? Yep. And right there, you'll see he's already putting more weight into that left side. And if you turn around, Anthony, and do that squat again, you'll, yep, yeah, just go back down. Yep. You'll see how he's shifting his weight off that right leg. Do you feel that?
Yes.
Somewhere midway, right there, you start to move over. And this is really what I say about physical therapists being movement specialists. And you just want to see, how is this person moving? And can you do something to affect it? And if you can, that's already doing what you need to do.
Perfect.
Does that make sense? Just by his history, just the way he was walking, you already are hoping, or just to confirm with just one more test. And then that just really nails it. So, single leg, knee to chest, really single leg, opening up that whole left hip capsule, right hip capsule on the posterior side. You're already thinking on those terms. So when you now give him his exercise program or his movement program, you're already saying, okay, I want to open that left, I want to stabilize the left side, I want to open that right side. I think my left and right is getting confused because of the screens. But the affected side is the side you want to open up, you want to stretch out. The other side is the side you want to stabilize. You want to do some unilateral exercises on that lumbopelvic hip complex, things like that.
Right. As far as any manual techniques that we could suggest for Anthony, what would you recommend? Because I know you did a really nice one for his cervical condition.
I would do the same technique for his lower spine. He can find one of those sweet spots in that lower back. And it's the same principle. You just want to, you're kind of finding like a fulcrum point using your own hand. If you can't do that on one side, you can always use a belt. Any men's belt, you can just pull the belt like you were tractioning. And there's some really nice videos out there where you can teach a patient to self-mobilize.
Oh, very nice. Do you know any of those websites offhand right now?
I think Mulligan has some on his, and then there's a lot of Mulligan trained therapists who have their own YouTube videos. So what I would do then is look for the lumbar video and then email it to Anthony so he can follow along.
Beautiful.
But I feel that's a really good way to go. And Theraguns are popular. If people own them, I'm like, knock yourself out.
Yeah,
especially
definitely.
when your hands aren't there. So it does help. Yeah.
Definitely. So Anthony, you could come back to the computer. Do you have any questions for either of us at this point in time?
Actually, yeah. What would cause something like my right side to be less favored over my left? Is that just by the way I'm sitting, or is that like over time, or is that from injury that I don't know?
Sometimes if you've played sport when you're younger, especially if it's a unilateral sport, you tend to get more wound up on that dominant side than the other side. Sometimes it's just the way the muscle mechanics work. If you had something on that right side, the right shoulder with that same right lat which goes into your back could be stiffening up. It could just be you favor this side more and so you overuse it. It's almost like you use your body 60-40, and then that 10% over all these years is causing that stiffness. It And usually I always say to people, it's always that one injury that offsets the mechanical change. So you really want to think about, why do I always use my right side? If it's the side you sleep on, it's the side you lift with, it's the side you do everything with, then that whole side feels a lot more overloaded than the other side.
All right. Well, thank you so much, Renuka. I think this was really a great way to share your expertise on the knowledge and everything surrounding e-visits. Thank you so much, Anthony, for coming. I really appreciate you letting us, see your movement patterns. And that's that.
Perfect. Thank you so much for having me.